Welcome back to the Curbsiders. I'm Dr. Matthew Frank Watto, here with my great friend and America's primary care physician, Dr. Paul Nelson Williams. Paul, when I'm traveling, what is something I should look at? I want some general tips to start off here.
When you're taking a travel history, let's say, Matt, a patient presents to your office and is going to be traveling someplace exotic, at least to us, what sort of history should you take and how can you counsel them best? So we talked to the great Dr. Boghuma Titanji, and in general, we tend to focus on the destination and the potential infections you can get in that destination. The way she thinks about it is you actually have to think of the substrate that you're treating, meaning the patient themselves, and what risk factors are they bringing into the party. It's probably worth noting that most of the mortality that happens with travel is not really related to infectious stuff, but it's because you didn't left when crossing the street. Or you had a heart attack because you're going to have a heart attack anyway. These types of counseling risk reduction, telling people to take their medications with them and having sort of contingency plans and getting traveler's insurance is probably some of the most useful stuff that you can do, in addition to counseling about the infectious diseases and planning about that, which we'll talk about. I'm also going to mention, Matt, that people's behavior might be different when they're traveling, which I think is not necessarily a good thing or a bad thing. It's just a thing. And sometimes that might even include engaging in sort of higher risk behaviors, including higher risk sexual activity. So it is completely within your wheelhouse as a primary care doctor to consider pre-exposure prophylaxis, or prescribe, or just give a handful of condoms, or just do some good counseling, or even consider post-exposure prophylaxis for the appropriate patient. So there is such a thing as sex tourism, and your patient may not share that part with you. So just kind of assume that someone might be more sexually active, make the offer, and at least protect them from those things as much as you're able to. But Matt, the other infectious stuff that we should focus on. Why don't we transition to mosquitoes and how we can counsel patients around those?
Yeah, you're right, Paul, because my mind with travel visits immediately goes to mosquitoes and malaria, which is what I'm going to talk about. But you're right. You're missing the bigger picture if you're not talking to them about everything you just said about their underlying comorbidities and their behaviors while they're traveling. But one behavior, people should be using insect repellent. They should be using insecticide-treated bed nets and trying to wear appropriate clothing to protect themselves both from the sun and from bugs while they're traveling. But even if they do that, Paul, it's hard to avoid getting bit by mosquitoes, which Dr. Titanji made that point. So even if someone's from an endemic area, she mentioned she's from Cameroon, but she's been out of the country for more than 6 months. She has lost her immunity to malaria, so she needs to take prophylaxis. And she said a lot of the times travelers will be a little bit more cavalier if they grew up in an area, but they're actually at risk. So with malaria, you can, if someone is leaving pretty soon, a daily med is probably the way to go, because you only need to start them a day or two before travel. Doxycycline, atovaquone proguanil, and primaquine are potential ones that you could start. With primaquine, you need to know whether or not they have G6PD deficiency. And then generally these are continued for 7 days or so after they get back, these daily meds. But with the weekly meds, which would include mefloquine and chloroquine, those have to be started roughly 2 weeks before they leave, and then they have to be continued for 4 weeks after they get back. So but they're once-a-week pills, so you can kind of negotiate with your patient, and sometimes the timing and their comorbidities may dictate which medication they're going to take. And then, Paul, are you giving people a just-in-case prescription for lumefantrine? But that's the medication to treat if they have like a malaria infection while they're traveling. You can give them a just-in-case med, or if they get back and they have a fever and you think they have malaria, you can treat them.
I have not had the opportunity to engage in this practice yet since we've recorded the episode, but I look forward to the chance to actively treat someone's malaria in the outpatient setting.
Same. So, yeah, and on the main episode, we go into the ins and outs of all the drugs. It'd be too much for this short video, yeah. But definitely you should feel comfortable in primary care, especially if they're not going to make it into a travel clinic. You can prescribe these medications, especially if the patient's in a pinch. Now, Paul, when I travel, I'm all about that street food, and I'm gonna stay with a local family, and I'm gonna just do what they do.
Yeah.
Am I at risk for traveler's diarrhea? I'm thinking no.
Those are the behaviors that potentially increase your risk for traveler's diarrhea specifically. It's again, as part of this travel encounter, in addition to the counseling around what medications to take and what shots to get, it's also important to remember to remind patients to wash their food with bottled water. So use bottled water for everything. So not just for drinking, but also for brushing your teeth, for rinsing things off that need to. Anything that may come in contact with your gut should actually be bottled and make sure that it's coming from a safe source. Street food, I know that that's kind of the romantic part of traveling in a way to engage with culture, but it's also a great way to be exposed to the local microbiome, which means it's your chance to get sick as well. So just engage at risk, I would say. I can't full-throatedly endorse it, though I can understand the temptation.
Now, Paul, when I inevitably get traveler's diarrhea from my street food eating, I'm going to want that Cipro, right? There's no resistance to that out there. That's first line.
Yeah, this was something that I learned in sort of preparing for this episode. I had thought about ciprofloxacin as a long time as sort of the de facto treatment for traveler's diarrhea, and it's actually azithromycin is I guess the newish kid in town, and really that's reserved more for the moderate and severe cases of traveler's diarrhea. The mild cases, annoying for sure, but not disruptive to activities. That's once it becomes disruptive to your day-to-day plans, that's when you've drifted into modern territory. And then if there's blood in your stool, then you've drifted fully into severe diarrhea and sort of dysentery. But it's reasonable to give an antibiotic just in case for those circumstances, but it's going to be azithromycin and not ciprofloxacin.
Now, Paul, it seems my travel instincts are way off, but I'm going to try one more time.
Great.
Okay, let's just pretend I'm a 75-year-old man. I'm pretty sick at baseline. I'm traveling to a country. I need the yellow fever vaccine. I'm just going to line up for that. No risk to me. Easy peasy. And
this is an important part, is where someone's traveling. Some countries do require you to have proof of vaccine, or at least a good medical reason to have not received the yellow fever vaccine. But it is a vaccine that is not without risks. Those risks include death, and that is a higher risk the older that you get and sort of the other comorbidities that you have with it. And these are not vaccines that can be given at your local primary care doctor's office. There are licensed clinics that do that, so it requires a little bit of organization and arrangement in advance too. So for our viewers and our listeners, know that you have to be aware of which countries require that, and then also you're probably not going to be the one giving it unless you work at one of these sort of special clinics, and that there are real risks involved in these vaccines, and patients should be counseled accordingly.
They can get like their Hep A, Hep B vaccine in the primary care office, tetanus. Those are all recommended, and those will be cheap because they're preventive medicine. But the yellow fever vaccine and some of the other ones that are more exotic, let's say, those are usually maybe $100 or a couple $100 to pay from a vaccine clinic or a travel medicine clinic. So you can call around and get the prices. Lots of great tips like this on this full episode. I definitely recommend people check it out, listen to it. They can click on the link in the transcript below. And with all that, until next time, I've been Dr. Matthew Frank Watto, and this has been another episode of the Curbsiders, bringing you a little knowledge food for your brain hole.
And I remain Dr. Paul Nelson Williams. Thank you and goodbye.